Here is the Week 5 coursework for VETT 134, continuing Chapter 3 on anesthetic agents and adjuvants, and as William Shakespeare said, to sleep, perchance to dream. Last week we had talked about several aspects of anesthesia. We talked about specific anesthetic and pre-anesthetic agents. We talked about tranquilizers, anticholinergics. We discussed opioids, and we got into the thiobarbiturates and barbiturates. And this week we pick up with the specific drugs themselves, starting off with thiopental. Thiopental is an ultra short-acting barbiturate. It's used in small animals and horses. Great stuff for horses. Has a rapid onset, but it has a brief duration of action. They will go down, they'll stay down, but they start waking up pretty quick. And they should have a complete recovery in 1 to 2 hours. It comes as a crystalline powder in multi-dose vials. It is reconstituted with sterile water or normal saline or 5% dextrose in water. You can use all those. I normally use sterile water. It is best mixed at 2 to 2.5%. You can mix it in higher concentrations, 4 even 5%, but in small animals you really want it at 2 to 2.5%. We mix it at 5% for horses. We need a little more concentrated drug in that case because we don't have such a huge volume to give those guys fast. Once it is reconstituted, you have about a week that you can use it before it starts going bad on you. About 3 days at room temperature. So if you are using thiopental, put it in the fridge and keep it there. Anytime there is a precipitate, it should be discarded. This should mix completely, be a nice clear liquid, and if you start getting precipitation in it, it has to be tossed. There is a variety of dosage range for thiopental. That will vary with whatever you're trying to accomplish, your procedure and the protocol you're using. In debilitated animals, you can reduce that dosage up to 80% because of the lack of fat and the distribution to lean muscle. We significantly reduce the dose in heavily sedated animals. Animals that may have had an opioid and acepromazine, for example, are going to require far less of a dose than one that's very awake, unsedate. We're going to give it to effect. We will titrate it in, give a little, give a little, give a little, give a little, nice and slow but steady, and then when they reach the point where most commonly they're going to be intubated, then we quit. We don't give a huge big bolus, and if we do, we end up in big problems. Repeated doses are cumulative and will lead to a prolonged recovery, so you are best to titrate your administration of thiopental, get them down, get them tubed, take them to gas, and not give any more. You can, but you're going to get some very long recoveries. It is not suitable at all for anesthetic maintenance. It is only for induction, and there are several different ways, protocols for administration. Mainly we're going to use it for induction, intubation, and we should have animals that are properly pre-anesthetized. Methohexital you will see occasionally used in veterinary medicine. It is an ultra short-acting barbiturate. It is similar in many ways to thiopental. It can be useful on an unfasted animal because it does not have a tendency to particularly cause emesis as much as some other drugs. It gives you a very rapid induction, rapid intubation, and if you have that tube in and that cuff is inflated, there's much less chance of the animal aspirating. If they do vomit, the tube should protect you. It also is a powder that must be reconstituted. We use sterile water in this case. You mix it at 1 to 2.5% solutions for small animals. I usually mix it at about 2. In most cases that seems to work extremely well. Shelf life is 6 weeks without refrigeration. So obviously if you mix a bottle with it, you've got a little bit more shelf life than you would with pentothal, where you have to get rid of it in a week or so. It is more expensive than pentothal. It is significantly more expensive than pentothal, and because of that, it is not often used in veterinary medicine. Actually, some of the newer drugs, Propofol, Etomidate, have made the barbiturates somewhat antiquated. To administer methohexital, we're going to get our dosage, draw it up. We're going to give a half to 1/3 of the calculated IV dose over about 10 seconds. that will almost always allow for intubation. If it doesn't, if they're still struggling, spitting, trying to cough that tube right back in your face, give an additional amount within about 30 seconds. Almost always that takes care of it. It can be used in sighthounds. Unlike Thiopental, which we try to avoid in the whippets and the greyhounds, this works really well. Can cause profound respiratory depression, and that's probably the biggest problem I've seen with it, is that it is a serious respiratory depressant. If you pre-oxygenate, if you ventilate, if you manage your airway well, you can overcome that, but don't be surprised if they just stop breathing. Excitement and seizures are often occur during induction and or recovery. You can help alleviate that with tranquilization, pre-anesthetics. You can control any problems you might see as far as post-anesthetic seizuring with diazepam. I have never seen it. I've heard stories. And you do not want to use it in animals with epilepsy, okay, because it does somewhat predispose to seizuring activity. I'll tell you the one thing about methohexital, you're more likely to get stage 2 during recovery than any other drug. Those guys will wake up and they will howl, okay? And you can give them a little ACE, you can give them a little diazepam or midazolam or whatever. That will smooth them out. But just be prepared if you're going to use methohexital, they're going to have some stormy recoveries. Pentobarbital is a short-acting barbiturate. It was used most commonly to treat status epilepticus. We now much more commonly use Propofol for that. The use of Pentobarb for status epilepticus is pretty much gone. Propofol does everything that Pentobarb does, only it does it far better with far fewer side effects. We administer it, well, some people administer it intraperitoneal to rodents for general anesthesia. I'm not sure, who's doing that anymore, but it's kind of very antiquated and kind of cruel if you ask me. Status epilepticus, if we are treating patients with Pentobarb for status epilepticus, give it IV, stop the seizure, produce heavy sedation. Problem is you can't keep giving it because there's a very narrow margin of safety. So if you're using it for status epilepticus, you got to be real careful with this stuff. That's one reason we went to Pentobarb, Propofol, because Propofol just works better and you don't end up with this cumulative stuff, and it's much safer, much better stuff. Pentobarb is usually provided as a 5% solution. You give it IV, you get a pretty good onset of action within 30 to 60 seconds. Okay, initially they just can't raise their head, then their jaw and tongue become relaxed. You will still get a little bit of a pedal reflex, pinch on a toe and they'll draw it back. If the pedal reflex finally goes away, then you can intubate them, provide respiratory support. Make sure you ventilate these guys because it is a very potent respiratory depressant. Duration of action is going to be anywhere from 30 minutes to 2 hours, so it is much longer lasting. You can give repeated doses, but your recovery time may be prolonged, and you may see some associated excitement as they emerge from Pentobarb. Pentobarb can produce some pretty stormy recoveries as well. And then we get into some of the good stuff, and some of the good stuff is Propofol. Propofol has kind of revolutionized how we provide veterinary anesthesia. It is an ultra-short-acting, non-thiobarbiturate anesthetic. It is used intravenous for anesthetic induction and for short-term maintenance. You can actually use Propofol for very extended procedures. You can use Propofol infusions for 4-6 hour procedures if that is indicated. Small animals, small ruminants, exotic animals, neonates of all species. This is a drug that is good across all ages and pretty much all species. Some species a little better than others, but all species it works. Other use, you can use an IV bolus and a CRI to treat status epilepticus in dogs and cats. That's where the beauty of Propofol comes about for treating status epilepticus. You give them the dose, you get them down, you put them on CRI, and you just suppress that brain until the seizuring activity goes away. Can't do that, really, with any other drug. This stuff just does not want to dissolve in water. Just does not want to dissolve in water. So it has to be dissolved in something else. And what it's dissolved in is an egg lecithin glycerin soybean oil aqueous solution. It is at 1%, which is 10 milligrams per ml. And it has a milky appearance. Everybody looks at it and it looks like coffee creamer. And they say you should never give anything IV you can't see through. That was what they taught us in veterinary school for a long time. Never give anything intravenously you can't see through. In other words, if it's cloudy. Well, this stuff looks like coffee creamer. Okay, but it is okay to give IV. You got to be careful with it, like anything else, but it works great. It is unknown how it affects GABA receptors, but it does. It is highly fat soluble, which is why it's such a good anesthetic. Onset of action is 30 to 60 seconds. Duration of action is 5 to 10 minutes. Okay, and complete recovery about 20 minutes in dogs, about 30 minutes in cats, and that's kind of what I see. Okay, that's about a good average. You give a bolus, you go down, they're down for 5 to 10 minutes. You can put in 2 sutures for a laceration, or pull a bad tooth or do something like that. They're awake, ready to go home. 20 minutes, 30 minutes for cats. Beautiful stuff. It does cause a dose-dependent depression on the central nervous system from sedation to general anesthesia. The more you give, the deeper they go. It is not analgesic. There is no analgesia. They are asleep. They are still feeling pain. The cardiovascular system, it is somewhat of a cardiac depressant, and it will cause a transient hypotension. Do not think that Propofol is not without effects. It is, but many of the effects are less pronounced than many of the other drugs. It is a pretty good depressant, and you will get apneas. Again, if you are pre-oxygenating and if you are managing your airway and ventilating, that can be ameliorated. We administer slowly to effect. Don't get in a big hurry. That's one of the big problems I see. People don't like Propofol. One reason they don't like Propofol is because you give it too darn fast. Pre-anesthetize, go slow. Pre-anesthetize, go slow. You'll love the stuff. And you need to, of course, monitor the patient carefully. As far as I'm concerned, if you give them a sterile injection of sterile saline, you need to monitor the patient carefully. Other things you may see with Propofol, you'll see some twitching during induction occasionally, and that's mostly because you'll get some myoclonus because you haven't properly anesthetized, pre-anesthetized the animal. With Propofol, I'll commonly use an anticholinergic. We'll commonly use, almost always use, a tranquilizer, an opioid. You'll get a nice, relaxed dog. Go slow. You don't really run into much muscle twitching. It is a good muscle relaxant. It is safe to use in animals with liver disease or kidney disease. Even though it is broken down by the liver, that's how it's metabolized, it is safe to use in animals with liver or kidney disease. In many ways, it is a good sick animal drug. It is a good appetite stimulant. So on occasion, it can have antiemetic properties, and it also decreases intraocular and intracranial pressures. Again, there are effects to Propofol. Some of them are bad. You will occasionally get transient excitement and muscle tremors during induction. Pre-anesthetize. You may get paddling, muscle twitching, nystagmus, opisthotomus, and resembling seizures. Pre-anesthetize. You will get cardiovascular system problems, particularly in the form of hypertension, which is fairly transient. Give them fluids, okay? Just expand the vascular space. You will occasionally get problems with the respiratory system. You get apnea, especially if you go push too fast. Don't get in a big hurry. Pre-anesthetize, intubate, ventilate, manage your airway. You can get, although I've never seen it myself, some sort of seizure-like signs during induction. I think, again, that goes back to not properly pre-anesthetizing. Those can be treated with diazepam. If you had used a tranquilizer to begin with, you probably wouldn't have seizure-like symptoms. There can be pain on injection. Perivascular injection does not produce any tissue damage. There's no sloughing, that kind of stuff. Most of the time, if we've properly pre-anesthetized, you've got an analgesic on board. They don't really have the problems with perivascular pain. Cats with repeat doses, you can get Heinz body formation. I've heard stories of diarrhea and anorexia, prolonged recoveries. I've really had very minimal effects of cats with Propofol, again, if it's used properly. Sighthounds, I've used it in sighthounds, and it works great. They say they can have prolonged recoveries if it's maintained on Propofol for more than 30 minutes. I mostly only use it for induction, And I can say that I don't seem to particularly have longer recoveries in sighthounds than other ones. But again, I haven't particularly used it. I suspect probably that's true, that if you use it on a continuing basis for long periods of time, you will probably get some long recoveries. But they're still not going to be obnoxiously long like, say, Pentobarb. Propofol should be given intravenously slowly over 1 to 2 minutes to effect. You can give it IM, and it produces mild sedation, ataxia only. There's absolutely no reason to give it IM. That's kind of silly. Dose will depend on how pre-medicated the patient is. If they are heavily pre-medicated, if they're very sedate, you're looking at around 4 mg per kg. If they're very awake and they're pretty with it, then you're looking at about 6 mg per kg. Draw that up, give it to even that to effect, and you're going to be fine. Propofol is highly bound to protein, so you do not want to use in any hypoproteinemic animals. This is not the drug for a dog or a cat that has a total solids of about 2.1. You avoid that like you would with the barbiturates. And it can cause excitement if given too slowly. If you're going instead of 1 to 2 minutes to 3 to 5 minutes, and yes, you can give too slowly, then you're going to figure out pretty quickly it can cause a little bit of excitement. If it does, just go a little faster. It'll catch up. Everything will be fine. Administering propofol, you can give boluses about every 3 to 5 minutes for 20 minutes. The truth is, you can give it for 3 to 5 minutes for about 4 hours, but it's best for short-term procedures. You can do a continuous infusion with a syringe pump or through an IV line, and it can maintain anesthesia for several hours. Use a low dose. You can control the depth of anesthesia. If they get too deep, then you back off on the infusion. If they get a little light, then you just speed up the infusion. And there are times, as when we get into specific protocols for various species, you'll see propofol for continuous rate infusion is going to be a really desirable drug. Recovery, dogs, it's complete in about 20 minutes, cats in 30 minutes. If you give 1 injection of propofol in a dog, it takes them 20 minutes to wake up. If you keep them down on a continuous infusion for 4 hours, the minute you cut it off, they're going to be awake in 20 minutes. One of the amazing things about propofol. It really is important to pre-med with tranquilizers. Okay? The people that have problems with propofol do not pre-med. You need to use a tranquilizer. It decreases the propofol dosage, and it also facilitates IV injection in unruly animals. You just makes it easier to get along with them. In sickies, you use something like diazepam or midazolam. In healthy animals, you can use a little bit of acepromazine for pre-medication. Propofol, because it is an egg lecithin glycerol soybean oil support, it will promote bacterial growth. It is like putting bacteria into milk. You know how fast that will grow those guys, how yucky that will get. It is important when we are using propofol to use as much as possible aseptic technique. Use aseptic needles, use aseptic sterile syringes. Make sure that you keep the top of the vial clean. If you don't use all the propofol, you really need to discard the unused drug within 6 hours of opening. I guess in my book, if you start at 8 o'clock in the morning, it needs to go by 5 o'clock in the afternoon, and anytime it's not in active use, it goes in the refrigerator. But at the end of the day, it needs to go. When we started, propofol was extremely expensive. It has gotten down to the point now where it is economically viable to use most of the vial of propofol, throw it away. Do not run the risk of using that vial over and over and over and over, 3, 4, 5 days. Just because you can't see something bad happening in that drug doesn't mean something isn't happening bad. And you can really damage or kill patients using contaminated propofol. If it is not opened, it has a 3-year shelf life. Works great. It is more expensive than ketamine diazepam. It is more expensive than Thiopental. It is a fairly expensive induction agent, but for that expense, you get an excellent, excellent drug in induction. When propofol first came out, a lot of people were using half Thiopental, half propofol for induction. It kind of gave you the best of both drugs, when it also took away the worst of both drugs. you may still see people that occasionally use half pentothal, half propofol for induction. But I think as thiopental has fallen into disuse, you don't see that happening. People are just using pentothal or propofol. Excuse me, too many P drugs. The dissociative anesthetics, phenylcyclidine and ketamine. Phenylcyclidine is known as PCP, angel dust. If you watch TV, they say, he was on angel dust, that's a horse tranquilizer. Well, they don't use it anymore. PCP is illegal. Nobody uses PCP or even has PCP, and if they do, they need to go to federal prison. The only one, well, we actually do use two. We use tiletamine and we use ketamine. Ketamine can be used alone in cats for minor procedures or to facilitate restraint. I don't know if you've seen where sometimes you get these wild cats and they sit in the back of the cage and they're absolutely crazy. You can squirt a little ketamine in their mouths and that will slow them down. It can be used with other drugs, and most commonly really does need to be used with other drugs. Tranquilizers and opioids can be used to induce general anesthesia, particularly with tranquilizers. At the sub-anesthetic dose, it is commonly used CRI for analgesia. Both ketamine as well as lidocaine can be used CRI and produce very, very good analgesics in low dosages. Not the kind that would induce anesthesia or that you use for procedures, but in very low doses on a CRI, ketamine is an excellent analgesic. One drug that is very popular and is a good drug is tiletamine. Tiletamine is combined with the benzodiazepine Diazepam. Any of the cyclohexamines, either ketamine or tiletamine, have a lot of bad side effects. Combining them with a benzodiazepine really makes a lot of the bad side effects go away. We commonly, because ketamine is not as heavy duty a drug, is not as big a dirty hairy as tiletamine, Valium works just fine for it. However, tiletamine is ketamine with an attitude. And so what we have to do is use a benzodiazepine with an attitude. And that benzodiazepine is Diazepam. Okay? And those two combined together are sold under the trade name of Tilazol. They can be used IM or IV to produce sedation, analgesia, and to facilitate intubation. They can be used alone. They can be used in combination with other drugs. Tiletamine, because particularly of the Diazepam, is a controlled substance. So again, we're going to have to keep DEA records closely with Tilazol. Tiletamine disrupts nerve transmission in some brain sections, and what we have is a selective stimulation in certain parts of the brain. It decreases pain windup through NMDA. I'm having problems with my letters today. NMDA inhibition, and it produces, like ketamine, a trance-like state. Animal appears awake. Their eyes are open, but they are immobile, they are unaware of surroundings, and you swear these guys are hallucinating. They've got to be chasing giant green bunnies everywhere. So the exact mechanism of action of any of the tiletamine or of ketamine isn't totally known, but we do know that they do and can produce certain types, not comprehensive, but certain types of very good analgesia. And there is a cat on ketamine. They're kind of rigid. Their eyes are open. They're staring off into space. They are somewhere, but their brain ain't around here anymore. So, and that's why we often use a tranquilizer like ACE or one of the benzodiazepines to give them a little more muscle relaxation to make it a little smoother for them. Ketamine, if you give ketamine IV, you're going to get pretty good action in 1 to 2 minutes. If you decide to go IM with it, and it does burn like the dickens, these guys really don't like those IM injections, it takes about 10 minutes to get your peak action. It'll last about 20 to 30 minutes. Increased dose prolongs duration, but does not increase the analgesic effect. Okay, increased dose prolongs the duration, but it does not increase the anesthetic effect. All dissociatives, ketamine, tiletamine, are either metabolized in the liver or excreted unchanged in the urine. This is why we need to avoid these drugs. Make a big star of this. Avoid these drugs in animals with liver kidney disease. You don't want to go using the cyclohexamines in animals with liver problems and especially with kidney problems. Some of these cats with chronic renal disease or blocked tomcats, we need to avoid ketamine at all costs. They are said to produce a dissociative effect on the central nervous system. And what you end up with is like cataleptoid-like state. They're in catalepsy. They have pretty much intact reflexes. They have palpebral, corneal, pedal, PLR, laryngeal, swallowing, several others. Their eyes are open. They have a centrally dilated pupil. Boy, those eyes are wide open. And you need to use an ophthalmic ointment because they don't blink. But it's like their body is there, but their brain has gone to a different universe, to a different place, a place full of bright colors, a place like the 60s, okay? Far out, man. It is weird stuff. It is weird stuff. And I've known people that have had ketamine, and they say, you know, it's like my body is here, I'm over there, I'm watching them cut my leg off, and I don't care. You know, I just don't care. I kind of feel it, but I just don't care. Disassociate. You disassociate you with what's going on to you. On dissociatives, animals have quite a bit of muscle rigidity. They really are stiff. That's why we use it with either H-promazine or a benzodiazepine. They have pretty good somatic analgesia. They have some degree of analgesia. It does produce somewhat of an amnestic response in humans, although I said I've had people that had ketamine and they can remember some of what happened to them. And there is sensitivity to sensory stimuli. If you make a loud noise, they jump, okay? Or if you poke them, they will react. There are some rather interesting physiological effects of the dissociatives, the cyclohexamines. They seriously increase heart rate, okay? I mean, they kick it way up. They seriously increase cardiac output. They increase mean arterial blood pressure, and the effects are due to the cyclohexamine stimulation of the sympathetic nervous system. One of the benefits you may want from a cyclohexamine in animals that may have a low mean arterial blood pressure or may need a little bit of stimulus to the circulatory system, they can provide that for you. Okay, they can really kick up heart rate, cardiac output, blood pressure to significant levels. The respiratory rate and the tidal volume may change. Respiratory depression with the cyclohexamines is usually very insignificant. They just keep on trucking along, you don't even know it. And you can get apneustic respiration at higher doses, but I don't think we're usually going to get to dosage that high that we start to see that kind of respiratory pattern. Individuals on any of the dissociatives are responsive to sensory stimulation. We need to avoid any of these drugs in animals with a history of seizure disorders because they will promote seizuring. We need to avoid in animals that have ingested any kind of CNS stimulants. You really don't want a cat on cocaine getting ketamine. It is not going to be pretty at all. We want to avoid animals that are undergoing any kind of neurological system procedures. All it does is it messes up the CNS. You're going to have absolutely no validity to any kind of neurological procedure. It does cause hallucinations and personal injury. People on PCP or people even on ketamine report some rather unusual hallucinatory procedures. So, you know, somebody on ketamine just decides, hey, I think I'll cut off my hand, see what it feels like. Oh, that's cool. And prolonged exposure or large exposures to cyclohexamines can cause personality change. And I have seen cats that received large injections or, you know, repeat injections at lower levels of particularly tiletamine that have undergone personality changes. They kind of go from mean, unhappy, cranky cats to sweet, loving kind of couch potatoes. I hadn't quite figured that one out yet, but you know, I'm sure some students would love to use on some of the teachers. And nystagmus, we will see nystagmus in these guys, eye twitchy stuff. And because it is such a powerful cardiovascular system stimulant, we really need to see and make sure we avoid the cyclohexamines, particularly with anybody that has had Heart disease, this is not a good drug for dogs with some types of cardiac existing problems. You can get arrhythmias, you can get responses to epinephrine release, and you get decreased entropy and all that kind of stuff. So, it's just best to avoid ketamine and all those guys on animals with underlying cardiovascular disease. You really need to avoid it with cardiovascular disease, liver disease, kidney disease. It's ketamine in many ways is a good, healthy animal drug. It's mostly the cyclohexamines are very safe for the respiratory system. They really don't do much, but you can get some degree of respiratory depress. Somebody can go into respiratory arrest itself. They do cause significant increased salivation and respiratory tract secretions. They do drool a lot. They get a lot of tearing. I suppose it's possible they could produce enough to aspirate some of these secretions, cause a foreign body pneumonia. But generally, cyclohexamines don't do much to the respiratory system. As we said before, these guys burn, 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 sting, sting, sting. If you give them IM, they hurt like the dickens, and you will get increased intracranial and intraocular pressure. To dose the dissociatives, whether it's ketamine or tiletamine, IM or IV, have a fairly wide margin of safety, especially so in healthy animals. They're extremely useful in cats and horses. Those are number 2 species. In dogs, Ket-Val is commonly used. Commonly used in combination with tranquilizers, ACE or possibly, Valium. For short procedures, that works good for anesthetic induction. For intubation, I particularly like Tilazol IV in cats to induce for intubation. Chemical restraint in cats for the wild ones, the really crazy ones. Large and exotic animals, they work real well. They are, in many ways, good analgesics, particularly if they're used specifically for certain types of pain. But there is no effective reversal agent. Unlike some of the other ones, there is no effective reversal agent. You give them, you're stuck with them. There's no way to make them go away. You can make the alpha-2 agonist go away. You can make the benzodiazepines go away. There's a specific agonist for the benzodiazepines, which is flumazenil. They go away. Ketamine, tiletamine, you just got to ride them out. Ketamine, we kind of covered a lot of this, but it's approved for use in cats and subhuman primates. Okay, it can also be used in dogs, birds, horses, exotic species. It's used for just about anything. It is a Schedule III drug. Okay, in the United States, it is a prescription drug. In Canada, it has a potential for abuse. It has a rapid onset of action, has a high lipid solubility, therefore it has a high onset of action, and you can administer it IV or IM. I generally like IM better, or IV better, IV better, and we can give it orally in cats. Again, the cat sitting in the back of the cage, squirt a little ketamine in their mouth, they'll be a much happier cat. You need to avoid repeat injections of ketamine. Give it once, walk away, don't give it again. Recovery is in usually 2 to 6 hours, although in some patients that can be extended quite a bit longer. Okay? Do not be surprised. Dogs break it down using the liver. Cats break it down using the kidneys. Okay? And that's why you really need these cats. You need a healthy kidney to give ketamine. Often used in combination with tranquilizers. I will say it really needs to be used in combination with tranquilizers, or you're going to get a rigid, unhappy, stormy cat or dog or horse. One combination that is commonly used is ketamine and diazepam. It really has a lot of advantages, works well in many situations. It is used intravenously for induction of anesthesia in dogs and cats. We mix equal volumes of diazepam and ketamine. They can be mixed in one syringe, but occasionally you will, for some reason that still escapes me, get a possible precipitate. If you do get a possible precipitate, you don't want to use it, although that's very rare. You give it IV, 30 to 90 seconds, you have onset of action. They are down, and you have good ability to intubate for 5 to 10 minutes, or even to do a short procedure. They take 30 to 60 minutes to wear off. Okay, and at the end of about an hour, most of these guys are pretty nice. They're pretty well stable. You can also use midazolam and ketamine. A lot of people are moving to midazolam. It seems to produce some smooth, nice, wonderful inductions, particularly in the sick, the old, and the young. Midazolam and those guys probably is a superior combination to diazepam. Diazepam works real good in the healthy animals, but in the ones that may be compromised or be at risk, midazolam seems to have a little more hemodynamic stability and do the job a little better. Tiletamine is similar to ketamine. It's sold in combination with Diazepam as a drug called Tilazol. Tilazol is a powder. You reconstitute it, sterile water. It's stable for 4 days at room temperature or about 2 weeks if refrigerated, so it has a reasonably decent shelf life. It is a class 3 drug. It can be used in combination with other tranquilizers or with ketamine. There is a possibility if it's used with other tranquilizers or ketamine, you can end up with some long and difficult recoveries. These guys can really have some problems. And like our old friend ketamine, tiletamine is going to be metabolized in the liver, secreted via the kidneys. There are some advantages to Tilazol over ketamine. Disadvantages is quite a bit more expensive. But the advantages are you're going to get a decreased apneustic respiratory response. They're going to breathe better. They're going to have happier respirations. It can be administered subcutaneously. Don't recommend it, but it can be. And Tilazol is actually extremely effectively used in some wildlife. If you're darting stuff down, things that you don't really want to mess with, like zebras, for example, it can be used very, very effectively. You got to know what you're doing, and you got to have somebody that's really trained in darting. But it can be an extremely effective drug for darting down those animals that do not wish to work and play well with others. Which brings me to one of my favorites, Etomidate. I'll sing the praises of Etomidate all day long. Etomidate is a non-controlled, you don't get in trouble with the federales, sedative, hypnotic, imidazole drug. It is used for induction of anesthesia in dogs, cats, exotics, and humans. It has, and this is what makes it so beautiful, minimal effects on the cardiovascular and the respiratory systems. It is extremely cardiovascularly stable. It is extremely happy with the respiratory systems. It is expensive. It's been a while since I bought any Etomidate, but for example, Propofol was running a little over or a little less than 50 cents per ml. Etomidate runs a little bit over $1. So it is more expensive, okay? But for animals that really need it, it will pay for itself 10 times over. You will get pain with IV injection. It does sting. So if you can, what you need to do is PA these guys. It can cause a little bit of nausea. Vomiting is possible. Humans report rapid induction of Etomidate. Nausea, vomiting can occur. Its mode of action is similar to the barbiturates, Propofol. All these guys are kind of working the same way. We have increased GABA inhibitory action. Etomidate has a short duration of action. You give it and it is rapidly sent to the brain, and then it is rapidly redistributed away from the brain. It has a very rapid metabolism. It has a wide margin of safety. It is a drug very often in human emergency situations. They grab it, they just make a wild guess what the dose is, and they give it, and they get away with it because it has a wild margin of safety. You know, if you have to get somebody intubated in the next 30 seconds, you're not going to grab your calculator and start figuring dosages. You're going to shoot and you're going to go. And that's the drug they use is Etomidate because, frankly, it is very, very safe. Etomidate produces some degree of hypnosis. There is very little, there is no analgesia with it. I'll tell you right now, there's no analgesia. However, big star, there is decreased brain oxygen consumption. Brain perfusion is maintained. So for animals that are head cases, may have cranial trauma, may have head problems or heart problems, some of these old dogs with really crappy hearts, man, Etomidate is a drug of choice. For head cases, for heart cases, and for emergency inductions, nothing comes close to Etomidate. Let me say that again. For head cases, for heart cases, and for emergency cases, nothing comes close to Etomidate for safety, ease, and stability of rapid sequence induction. It can also have some anticonvulsant properties, but other things do that a lot better, so we don't really worry about that much. Once it is given, there is an initial minor hypotension. I've never seen particularly much of that. However, Heart rate, heart rhythm, blood pressure, cardiac output, minimally affected. You can't even tell you gave this stuff. You pull it up in the syringe, you give it, heart rate, rhythm, blood pressure, cardiac output stay the same, unlike most everything else. You will get a little bit of initial apnea. There seems to be a lot of variation in these guys. It will cross the placental barrier. Again, you're going to support the respiratory system. You're going to tube, you're going to ventilate, you're going to maintain. It does cause some degree of muscle relaxation. There has been and will be spontaneous muscle twitching and movement. A lot of people really hate that about Etomidate. And what I tell them is, I don't care. You know, they're going to twitch. I don't care. A little bit of movement. I don't care. You know, it's not like they're picking up and running off across the room, running wild, crazy everywhere, pooping on things. Oh, that's a dachshund. No, they just, you know, they have a little twitching. I don't care. It'll go away. Don't sweat the small stuff. It can be painful on IV injection. Does burn a little bit. If it is given perivascularly, it can form a sterile abscess. Give it IV through a catheter. You can get a little hemolysis with very rapid administration in cats. Don't get in too big a hurry. In humans, there is decreased adrenal cortical function. There is a transitory adrenal cortical function depression. Does not seem to happen in animals. Okay, I'm not saying it can't, but I've never seen it and I don't see reports of it. And if you give it, there's going to be nausea, vomiting, involuntary excitement during induction, recovery. All those are often usually maintained or alleviated by using proper pre-anesthetics, plus the fact you're also going to understand you're probably using Etomidate because it's a head case, it's a heart case, or it's an emergency, and you don't use it for regular space. But in those guys, you know, you want to keep the head stable, you want to keep the heart stable, you want to keep everything, the really important stuff going. You know, as the heart and the head are working, who cares if they get a little nauseated? It doesn't matter. Oh, let's give something that doesn't nauseate them, but it'll kill them. Bad idea. You want to use something that's going to keep them alive so you can fix the problem. It is given IV. If you have the luxury, pre-medicate with an opioid or diazepam. Pre-medicate with dexamethasone to avoid the stress of adrenal cortical suppression if it does occur. And we can give, like Propofol, repeated boluses to maintain anesthesia. It's expensive, but man, it is hemodynamically stable to the nth degree. Another drug we'll come across, particularly in large animal medicine, is Guaifenesin. Okay, its previous name was glyceroglycolate. GGE, glycerol glycolate ether. You'll still hear it referred to as GG in some places, but it's Guaifenesin is most commonly referred to. It is a non-controlled muscle relaxant. It is commonly used in large animals. When we start talking particularly about equine anesthesia, it'll be one of the constituents of triple drip. It does produce excellent muscle relaxation, helps facilitate intubation, makes a smoother, easier, happier recovery. It is not an anesthetic. It is not an analgesic. How it works is not particularly well understood, but if you give it to large animals, particularly to horses, they are going to have muscle relaxation and they're going to have a much smoother anesthetic event. Effects of Guaifenesin, good stuff. It produces excellent skeletal muscle relaxation. There's minimal effect on the diaphragm, so you really don't depress respiration very much. And there's just minimal effects on the cardiovascular and respiratory system. In horses, works great. Unless you misdose Guaifenesin, there's almost no adverse effects on these horses. If there is an overdose, you will get some degree of muscle rigidity. They'll go from relaxation to rigid. You can start getting some apneustic respiratory patterns. If it's given outside the vein, it will cause perivascular tissue irritation. And in high concentrations, if you don't dose it right again, you can end up with some hemolysis in ruminants and horses. We don't see hemolysis that much. You kind of got to mess up pretty bad to do that. We commonly will use GG with ketamine in anesthetic inductions. We will almost always, particularly in horses, pre-medicate with an alpha-2 agonist like Rompin or acepromazine, or maybe both in some cases. And then we will give this IV, and it produces excellent anesthetic and muscle relaxation. Triple drip is a combination of glycerol glycolate, or Guaifenesin, ketamine, xylazine, used in horses. The maximum duration is for about an hour. 45 minutes in my book. I get nervous after about 45 minutes. But you induce, give some xylazine, then ketamine, they go down. You hook them up to a combination of Guaifenesin, ketamine, and xylazine in a bag at a drip, and you can do a great job of maintaining anesthesia. It is often administered intravenous rapidly until the animal is ataxic. You can take some of these horses, get them a good pre-med, and then drop them almost exclusively on Guaifenesin. Now, I don't like it, but that's the way it goes. And you will induce when the patient gets really, really ataxic, they're about ready to fall over, and it produces a remarkably smooth recovery. I know some people that do that. It's not my forte, but it does work well. Remember, it is not a sedative. It is not an analgesic. It is a muscle relaxant. And when you're dealing with 1,100 pounds of horse or 1,200 or more, you need muscle relaxation. Okay? A rigidity in a horse is not a pleasant thing. You have to PA them. You need to pre-medicate them. If you give it without pre-medication, there can cause excitement and some rather unpleasant side effects. And there is an increased risk of any of the unwanted or untoward side effects if there's no medication. You got to pre-med these guys. If you do, it works great. Great muscle relaxant, works great in triple drip. The inhalants. And often when we think of inhalants, we're thinking of anesthesia. And if we're thinking of anesthesia, we're thinking of inhalants. The two most common we're going to use are isoflurane and sevoflurane. Occasionally you see somebody still using nitrous. It's just almost antiquated now. I've heard people using desflurane is more commonly used in human medicine because the vaporizers and the anesthetic are so extremely expensive. Enflurane was used at one time. Halothane was used at one time, and I know a couple of equine people that are still using halothane, and for adult horses I think halothane is great stuff. Methoxyflurane is not used anymore. It is extremely toxic to the kidneys. We don't use it on animals. We don't even want to be around it as people because of what it'll do to us. And I suppose there's probably somebody out there still with an old cone and some ether just, knocking out animals. It's kind of out there with stone knives and bear skins. And there's good old diethyl ether, good old ether. Going back to Morton, the heydays of anesthetic delivery, it's no longer used. People just don't use ether anymore. The original stages and planes of anesthesia were described and documented when we first started using ether. And for a long time, ether was all we had. I mean, for decades, ether was all you had. Ether has some pretty decent characteristics. It does do a pretty good job on the cardiovascular system. You have a stable cardiac output, the heart rhythm's good, blood pressure remains pretty decent. It is not terribly hard on the respiratory system, and it will produce a pretty good muscle relaxation. But like everything, this coin has two sides. It is extremely irritating to the trachea and bronchial mucosa. And if you're doing cone inductions, these people or animals cough and retch and retch, and it is just like breathing liquid fire. It takes forever to go down. It takes forever to wake up. There is post-operative nausea. There is vomiting. You wake up feeling like you just want to die. You'd rather die than go through the induction with ether. And it is flammable. It does love to burst into flames, and it is explosive. It likes to blow up a lot, okay? And having flames and explosions in the middle of your surgical procedures is counterproductive to good patient care. You might want to write that down. Flames and explosions during surgical procedures is counterproductive to good patient care. Fortunately, we're going to move on to a little bit more modern anesthesia, and we're talking about isoflurane, sevoflurane. They are the most commonly used agents of the halogenated organic compounds. They are liquid at room temperature. You pour them out of the bottle as a liquid. They are then placed and stored in a vaporizer on an anesthetic machine, as you should know by now, and they are then vaporized as oxygen flows through the vaporizer. The oxygen picks up in hopefully a very precise concentration. The iso or sevo delivers that to the patient. As you are probably aware by now, we put liquid anesthetic in a vaporizer, either iso or sevo. As the oxygen flows by, it is vaporized, mixed with the oxygen. That mixture of oxygen and anesthetic is delivered to the patient by either a mask or an endotracheal tube. The mixture travels down into the lungs, down to the alveoli. From there, through diffusion, it moves into the bloodstream. The diffusion rate is dependent on the concentration gradient, or how many alveoli and capillaries, as well as the lipid solubility and concentration gradient, that is, the anesthetic moving from the alveoli into circulation, is by far the greatest during initial induction, because there's the biggest diffusion, biggest difference in high levels and low levels. The distribution of the inhalants is dependent on the blood supply. Lipid solubility will determine entry into tissues through cell walls. This is true for just about everybody, how lipid soluble it is, because we're passing through a lipid membrane. The depth of anesthesia is dependent on the partial pressure of the anesthetic in the brain. How much is actually in there? Partial pressure in the brain is dependent on the partial pressure of the anesthetic in the blood and the alveoli, which is just another way of saying if you give them more gas is going to go to the brain. The more gas there is in the brain, the more anesthetized they're going to be. And the maintenance of anesthesia of the inhalants is dependent on sufficient quantities of anesthetic delivered to the lungs. If you can't get the anesthetic into the alveoli, as long as the alveoli and the circulatory system are working properly, then you're not going to get any anesthesia. If you've got your system working great, no problems. But if there is a problem in the vaporizer, in the machine, in the breathing apparatus, in the endotracheal tube, then you're not going to get a smooth, steady, predictable anesthetic event. If we reduce the amount of the anesthetic that's delivered to the alveoli, in other words, we turn the machine down or even off, then through diffusion, we are going to have the anesthetic move from an area of higher concentration, in this case in the bloodstream, to an area of lower concentration, to the alveoli, and then out of the body. Blood level is initially higher than alveolar level, and then as we reverse that, the opposite will be true. Concentration gradient, as we eliminated the inhalants, favors anesthetic diffusion from the blood into the alveoli. There's higher levels in the blood. We turn the machine off. There's none in the alveoli. It'll move from an area of high concentration to low concentration out of the alveoli, out of the circulatory system, into the alveoli, and then out of the body. Blood levels will drop quickly as the patient breathes out anesthetic from the alveoli, from the blood to the alveoli, out the tube, into the machine. Brain levels drop as less anesthetic is delivered. If we're pulling it out of circulation, then they're going to wake up and they will do just fine. So we deliver high concentrations, goes from the alveoli to the blood to the brain. When we turn the machine off or way down, it goes from the brain to the blood to the alveoli, back to the machine. Almost, again, all these guys are going to have a lot of similar characteristics. Inhalants, we're going to have a dose-related reversible CNS depression. The more gas you give them, the deeper they're going to go, and hopefully, when you stop giving them the gas, they're going to wake up. They can be hypothermic, just because you're depressing the centers in the brain that regulate temperature regulation. We can depress the cardiovascular function, but with inhalants, the effects on heart rate are variable. You can see a lot of variation. I think primarily from individual to individual on how much heart rate function or how heart rate variability you're going to have. They are real good respiratory depressants. There's no doubt about it. The more you give, the more ventilation depression you're going to have. Particularly isoflurane seems to be that way. You're going to see increased intracranial pressure in patients with head trauma or brain tumors. You really want to avoid the inhalants with head cases if you can avoid them. Sometimes you don't have a lot of choice, but just be aware they can increase intracranial pressure. They are considered safe for epileptic patients. They do not seem to predispose to seizuring in those animals that have a history of seizuring. They decrease blood pressure. They are pretty good blood pressure depressants and can decrease renal blood flow. If you have animals that are particularly sensitive, some of these old cats with chronic nephritis or chronic interstitial nephritis, you may want to use things to increase blood pressure to the kidney, increase fluids, sympathomimetic drugs, those kind of things. And they will almost invariably hypoventilate, and they will end up with carbon dioxide retention and with respiratory acidosis. A lot of that can be alleviated with, yes, wait for it, you know it's coming, pre-oxygenation, rapid intubation, ventilation support. Let me say that again. All that can be alleviated, prevented, accounted for with pre-oxygenation, rapid intubation, ventilatory support. You will need to understand and go through, and there are some questions on this, but not terribly a lot of questions. Vapor pressure, the parturition coefficient, minimum alveolar concentration. I love my minimum alveolar concentration. MAC is cool stuff, as well as their solubility in rubber or rubber-related type products. Know what vapor pressure is, know what parturition coefficient is, know what a MAC is and how it can be used, and the rubber solubility of these agents. Vapor pressure is the tendency of an inhalant anesthetic to vaporize to its gaseous state, to go from a liquid to a gas. It determines how readily an inhalation anesthetic will evaporate in the anesthetic machine vaporizer. Okay? They do not go from a liquid to a gas at the same rate. Some of them go very fast. Some of them go very slow. Their vapor pressure is usually going to be temperature and anesthetic agent dependent. The greater the temperature, the more they vaporize. Okay? It just makes sense. And also there is a lot of variability from agent to agent to agent. Volatile agents, the ones we're talking about, have high vapor pressures. If they didn't, they wouldn't get into the body. Okay, they would never volatilize. They'd be sitting in that vaporizer in a liquid state 2 years from now. We're going to talk about isoflurane, sevoflurane, desflurane, and halothane. Those are the ones you'll see in veterinary medicine, and of those, 99% of the time it's iso and sevo. They should be delivered from a precision vaporizer to control the delivery concentration. If we want 2.5%, we need to make sure it is 2.5% no matter what. No matter what the atmospheric pressure is, the temperature is, the humidity. We want it precise. All precision vaporizers are made to deliver only one specific halogenated agent. You can't use iso in a sevo vaporizer or sevo in a halothane vaporizer. You got to use that particular one or it means nothing. Non-volatile agents have a very low vapor pressure. For example, our old friend methoxyflurane. Those are delivered from a non-precision vaporizer because you have to have a huge wick surface area to get this stuff into a gaseous state. Methoxyflurane just is not a viable agent anymore. We'll talk about it. We'll use it as an example of things that are bad. Okay, methoxyflurane, bad. The blood gas parturition coefficient is the measure of the solubility of an inhalation anesthetic in blood as compared to alveolar gas or air. Okay? It is how soluble something is in blood as compared to how soluble it is in air. It is an indication of the speed of induction and recovery for an inhalation anesthetic agent. If we have a low blood gas parturition coefficient, that means the agent is more soluble in alveolar gas than in blood at equilibrium. You got 2% in the alveoli, you got 2% in the blood that wants to stay in the alveoli. Agent is going to be less soluble in blood. And what you're going to expect is a faster expected induction and recovery because it does not want to stay in the blood. Okay? It just doesn't want to stay in the blood. It will go in the blood. They go down fast. But they also come up fast because It doesn't want to stay in the blood, okay? It wants to go back to air. If we have a high blood gas parturition coefficient, the agent is going to be more soluble in the blood than in alveolar gas at equilibrium. The agent is going to be less soluble in alveolar gas. The agent is absorbed into the blood and tissues like a sponge. It's sucked in there. Because it's sucked in there, it doesn't want to come out. Okay? It just wants to stay there. So you're going to have a slower expected induction and a really slower recovery. Okay? It just doesn't want to do what it's supposed to do. Because of that, everything is slower. The blood gas parturition coefficient determines the clinical use of the anesthetic agent. For example, can a mass be used? You know, if it takes years to get an animal mass down, we don't want to use it. How fast will the anesthetic depth change in response to changes in the vaporizer? If we want to get them down a little deeper, we don't want it to take forever. Okay? Or if we want to lighten them up, it shouldn't take forever. And finally, how long will the patient sleep after anesthesia? Will they sleep for minutes, hours, days, months, years? Okay? That's going to play a role in our choices of anesthetics. Minimum alveolar concentration, or MAC, is the measure of the potency of a drug, of an inhalant. It is used to determine the average setting on the vaporizer that will produce surgical anesthesia. If you got a brand new anesthetic tomorrow, which we'll call Igelnibofribits, if you knew the MAC of Igelnibofribits, you'd have a pretty good idea of what you would set your vaporizer setting on to maintain anesthesia. The lower the MAC, the more potent the anesthetic agent, and the lower the vaporizer setting. Okay? So, you know, something that you can keep at 1% versus, say, 5%, it's going to be a lot more potent. Okay? It's going to produce better anesthesia. MAC may be altered by age, metabolic activity, body temperature, disease, pregnancy, obesity, political party affiliations, color of shorts, whether or not they wear glasses. MAC can be, it is so all over the board because there's so much variation in individuals, but it's a good starting point. Every patient must be monitored as an individual. And I'll tell you, we can say, set isoflurane at 2% for maintenance. Well, 2% on some patients, they're going to be walking off and headed down the hall. 2% in other patients, and they're going to be in stage 4 so fast it will make your head swim. So you have to monitor the patient and adjust accordingly. Average vaporizer settings are just that, average. There is no average animal. There is only individuals. As far as the specific inhalants, isoflurane is the most commonly used inhalant agent in North America. Okay, ISO is still, in many ways, the gold standard. It is approved for use in dogs, horses, commonly used in other species. So we use ISO on cats. We use ISO on everybody. It has a high vapor pressure, therefore we will need a precision vaporizer. ISO does not work well in wick vaporizers. It has a low blood gas parturition coefficient, which means they go down fast and they wake up fast, certainly in comparison to a whole lot of things. It is good for induction with a mask or chamber, although I will warn you, with isoflurane, it stinks. They don't want to breathe it. Okay, so there's quite a bit of breath holding. It is also a direct respiratory depressant. When the ISO starts hitting the respiratory centers in the brain, they don't want to breathe. If they don't breathe, they don't go down. The MAC is about 1.3% to 1.63%, helps determine the initial vaporizer settings. Okay, low rubber solubility. It doesn't want to stick to the rubber, doesn't permeate the tubes. It's stable at room temperature. No preservatives are needed. It is an excellent inhalant. ISO does a good job, and certainly in comparison to other things, of maintaining a decent cardiac output, a good heart rate, a steady, predictable heart rhythm. It has probably the fewest adverse cardiovascular effects. Okay? It is really a good, stable inhalant. It will depress directly and indirectly the respiratory system. Okay, wait for it. You have to pre-oxygenate, make sure you have rapid and sure endotracheal tube placement and ventilatory support. They just don't want to breathe. Does a good job of maintaining cerebral blood flow, almost completely eliminated through the lungs, which means it doesn't hurt the liver or kidneys. Induces adequate to good muscle relaxation. You don't need anything else along with it. No analgesia. Okay, just don't count on it. It's not an analgesic, it's an anesthetic. And can produce carbon monoxide when exposed to a desiccated carbon dioxide absorbent. Okay, you can produce carbon dioxide, but it is very rare, and we don't really worry about that very much. Isoflurane's little brother, sevoflurane, commonly used, has a high vapor pressure. You need a precision vaporizer, no wicks here. It has a good rapid induction and recovery, good for induction with a mask or chamber. It has a high controllability of depth of anesthesia, has a MAC of 2.34 to 2.58%. Sevo is known. Fast down, fast up. Okay, and in human medicine, you can put a mask on somebody, a kid or something, they have about 3 or 4 whiffs of Sevo, they're out. Okay, rapid induction. Sevo has minimal cardiovascular depression, has about the same respiratory depression as isoflurane does. They just don't like to breathe it. It is limited by the lungs. There is a little bit of hepatic metabolism, not a lot. Does a good job of maintaining cerebral blood flow, good for heads. Induces adequate muscle relaxation. They're going to be relaxed. You can do your procedures. And a lot of people report, if you don't really especially properly pre-anesthetize, you're going to get some paddling, some excitement during recovery. To me, I see more problems with Sevo during recovery than I do with ISO. By saying problems, I mean paddling, excitement, things that aren't dangerous to the patient, but are particularly unsightly, just kind of those yucky things you go through that aren't going to kill anybody, but you wish you could avoid anyway. DES is closely related to ISO. It is real expensive. DES is really expensive stuff. The vaporizers themselves are in the tens of thousands of dollars. It has its place in human medicine. I just don't see a place for it in veterinary medicine unless somebody gives you one of those darn vaporizers and you get a little bit of DES and you just want to try it out. It has the lowest blood gas partition coefficient. Very rapid induction, very rapid recovery. It is used with a special spelled EXPENSIVE, precision vaporizer. Okay, it is really, really, really expensive. And that's why you will see a lot of people in human anesthesia that don't like DES just because it's too fast. It's just too, it's like giving a teenager that just got their driver's license a Ferrari. Okay, it is just, you can blink twice and the patient is overdosed. The MAC, look at this, 7.2, 9.8. It is the least potent inhalant agent, and man, you are down fast and you are up fast. It goes in the lungs, comes out the lungs, minimal. Good thing about DES, minimal body metabolism. The desflurane, strong vapors cause coughing and holding the breath. It is pretty potent. If you ever smell DES, it actually makes isoflurane smell pretty good. Other effects are very similar to ISO. It's ISO's brother, but it is much more potent, much more rapid. You will get a transient increase in heart rate and blood pressure in humans, minimal in animals. The other agents, halothane, it's not commonly used anymore. It's been replaced by ISO and Sevo. The only place you see halothane, the old trade name on it was fluothane, is in equine anesthesia. I think there's still a few people using it. I'm not even sure you can get halothane anymore. Last I heard, to get it, you had to import it from Australia. Methoxyflurane, not used. Influrane, it was used primarily in human medicine. It's not even used particularly in human medicine anymore. Nitrous is a real good muscle relaxant, used primarily in human medicine. There is occasional use in veterinary medicine. We just don't use it. It's a gas at room temperature. It comes out of the bottle. It's mixed with the oxygen, used to produce muscle relaxation. It potentiates the inhalants, but really, there's no reason for us to use it. There's no viable reason for using nitrous in veterinary medicine at all. Another agent we need to mention as we come to the end of the inhalants is Doxapram. Doxapram is an analeptic agent. It stimulates respiration. It is a vigilance stimulator. It brings and hurries the patient back to consciousness. Their mentation gets better much more rapidly, speeds recovery. Okay, it is used in neonate puppies and kittens after C-section, stimulates respiration, gets them going, makes them do better. It can be given IV or in sublingual drops to neonates. In adult patients, if you need to stimulate respiration, it is used IV. You can give it through the catheter, you can give it through the sublingual veins. If you can find a vein, you get it in. It will greatly stimulate recovery, greatly stimulate respiration. Doxapram has a real place in our profession, besides in the emergency box. It does have a wide margin of safety. It can lower the seizure threshold, so if possible, avoid it in use in animals that have a history of seizuring. And in overdoses can cause CNS damage. Okay, it is a potent drug, but at the doses we are using, talking about, any chance of CNS damage is almost non-existent. To stimulate respiration, to really get the patient back, repeat injections may be necessary. It will reverse respiratory depression from inhalants and barbiturates. Those guys that are just hanging will not wake up. And you wait and you wait and you wait, and their respiration is poor and they just can't get going. And they're just, it's like they've been there for a year. You can give them some Doxapram judiciously, proper dosage, proper route, and invariably their respiration is going to pick up. They're going to blow their breath a few times. They're going to suddenly wake up, look up, and spit the tube out. If they don't do that, you got real problems with that patient. But in those patients, it can be a real effective adjunct to stimulating recovery from anesthesia.